Greetings, I'm Doug Schwinn, and this is the third step in the Marchi algorithm, respirations. The R in Marchi is for respirations. This part of the algorithm is based on assessing for proper respiration. Provider assesses for bilateral rise and fall of the chest and appropriate lung sounds. The primary concern is assessing for and treating tension pneumothorax, sucking chest wounds, and supporting ventilation as required. Interventions in this part of the Marchi include assisted ventilation, chest seals, and needle chest decompression. In a casualty with progressive respiratory distress and known or suspected torso trauma, consider a tension pneumothorax and transport to the hospital as soon as possible. All open or sucking chest wounds should be treated immediately by applying a chest seal to cover the defect. Monitor the casualty for respiratory distress. Pneumothorax. A pneumothorax is a collection of air between the lung and the chest wall due to an injury to the chest or lung. This is treated by performing a needle chest decompression. Tension pneumothorax. A tension pneumothorax is worse than a pneumothorax. Injured lung tissue acts as a one-way valve, trapping air between the lung and the chest wall. Pressure builds up and compresses both the lungs and the heart. Some of the signs and symptoms of a tension pneumothorax are decreased or absent breath sounds, increased cyanosis and air hunger, apprehension and agitation, possible subcutaneous emphysema, or a very late sign is tracheal deviation towards the normal or unaffected side. Tension pneumothorax is another common cause of preventable death encountered on the battlefield. Tension pneumothorax may occur with entry wounds in the chest, abdomen, shoulder, or neck. Blunt force trauma, such as motor vehicle accidents, or penetrating trauma, such as gunshot or knife wounds, may also cause tension pneumothorax. It is easy to treat in the field setting. Both lung and heart function are impaired with a tension pneumothorax, causing respiratory distress and possibly shock. Treatment is to let air trapped under pressure escape. This is accomplished by performing a needle chest decompression. That's what I have here are needle decompression kits. There are two different gauges. The one on the left is a 10 gauge needle, while the one on the right is a 14 gauge. I'll show you the difference in size, and you can see why the 10 gauge needle is more appropriate than the 14 gauge. So this is the 10 gauge, and as you can see, it's a significantly larger diameter and will allow more air to escape in the case of a tension pneumothorax or a pneumothorax. That 14 gauge, the one here, used to be the standard gauge, but they found through the last 5 years of battlefield study that 10 gauge is the preferred gauge for treating pneumothorax or tension pneumothorax. Needle chest decompression, or NCD. There are two acceptable sites to perform a needle chest decompression. The anterior location is the second intercostal space along the lateral aspect of the midclavicular line. The lateral location is the fifth intercostal space on the anterior axillary line. Anterior needle chest decompression site. The anterior location is the second intercostal space along the midclavicular line. Start at the middle of the clavicle, go 2 to 3 finger widths below this point. Do not insert the needle medial to the nipple line. Lateral needle chest decompression site. The lateral site is the fifth intercostal space at the anterior axillary line. The fifth intercostal space is located at the level of the nipple on young, fit males. The anterior axillary line is located approximately at the lateral aspect of the pectoralis major muscle. Using this site may reduce the risk of complications from needle decompression as it is more remote from the heart and great vessels. These pictures show the insertion of a needle chest decompression at the anterior location and the catheter remaining after the needle is removed. Sucking chest wound or open pneumothorax. air enters the pleural space through a wound in the chest wall. On inspiration, air enters the chest through the hole instead of through the trachea. The affected lung cannot be fully reinflated by inhalation. Sucking chest wounds may result from large defects in the chest wall and may interfere with ventilation. Treat by applying a chest seal completely over the defect. Monitor for possible development of subsequent tension pneumothorax. Allow the casualty to adopt a sitting position if breathing is more comfortable. On the table before me are a number of instruments and interventions used to treat chest trauma. I will go more in depth on a few of these and then provide hands-on demonstration. There are a number of different chest seals that are available in order to treat chest trauma. This is one of the more common ones that we find in the military, and this is a halo chest seal. As you can see, it does not have a valve, but it still performs rather well at fixing the defect in the chest wall. Here's another chest seal. This one happens to have a valve on it. It performs the same as the other type of chest seal. When using this one, it's important to remember that the valve goes directly over the defect in order to allow trapped air to escape during the patient's normal respiration cycle. Right, one of the important things to remember when treating a penetrating chest trauma is to ensure that whatever chest seal you're using covers the entire defect. So this right here is our defect. We're going to use the halo chest seal. So one thing to remember is we're going to wait until the patient is on his expiration before we apply the chest seal. All right, so we assume he's exhaled, and before he takes his next breath, all we're going to do is make sure that we cover the entire defect, that the edges are nowhere close to the wound, because we run the risk of the seal not being good, and that kind of defeats the purpose. So obviously this one doesn't have a valve, so we don't have to worry about centering that over the defect, but we want to make sure that it's relatively smooth, contours to the body, and this will assist him in his respirations moving forward. Okay. All right, so you just saw the video on treating penetrating chest trauma with a chest seal without a valve. This is a SAM chest seal that happens to have a valve, and it's a one-way valve that allows air to escape the chest wall. The important thing to remember is when you apply a chest seal with a valve, the valve needs to go over the defect. So let's see if we can do this. All right, and just like the other one, you're going to wait until the patient exhales fully, and then you will apply the chest seal over the defect, making sure that the valve is not obstructed and that all the sides of the chest seal are down. This concludes the third step of the March E algorithm.